Om Shri Manjunataya Namaha. Om Shri Dhanvantare Namaha. Good morning, everyone. Welcome to the today's session of Emergency Management class series. Without further delay, I will welcome Dr. Molidhar Sharma sir, Professor Emeritus, Department of Shalyatantra, SDMCA Udupi, to take over the session. Welcome, sir.
Okay. Now, we'll start with the new chapter, that medical emergencies and emergency medicine. Word emergency medicine is interpreted in a different manner and to different situations. In different countries or different medical disciplines, there will be some different interpretation of that. From Indian point of view, the emergency medicine is a medical specialty dedicated to the diagnosis and treatment of unforeseen illness, unimportant, or injury. So it's something like the casualty department. And also, it also involves plan the immediate aid that should be provided to the patient according to his or her medical condition. And very specifically, it involves many steps. One, triage, they evaluate, stabilize, diagnose, and disposition of the patient. The first is the triage. Triage is to assess the risk of the patient, like risk to the patient, whether the patient has a high risk to the life or whether the patient can sustain the life of the patient, and that also decides like how far you have to be energetic in the treatment of the condition. Now, when we say emergency, it starts with the emergency medical kit. So, the basic essential needs which are to be there in a emergency medical kit are: one, you have to have a supply of oxygen, AMBU bag, endotracheal tubes, IV cannula, IV fluids, syringes, suction, defibrillator, tourniquet, and suturing set, bandages, rail tube catheter, and medicines, of course. A few groups of the medicines like steroids, adrenergics, parasympatholytics, local anesthetics, analgesics, and sedatives. These are the basic essential contents as per our accreditation standards. Emergency medical kit should have at least these materials in. Now, that's about the basics as such. Now, we'll directly go into one of the common emergency conditions. One of the common emergency condition is patient who is brought in an unconscious condition, an unconscious patient. Now, a patient being brought in an unconscious condition may be of two categories. One, where you may get sufficient information about the cause and the environment where the patient had become unconscious, so you may get better clue to know about the cause of that. But there is another category of the patient who is a real emergency where the exact reasons for the unconsciousness are not known. Patient is brought without a proper history and how to approach that. So we'll start with the dealing with an unconscious patient where you do not have a information about the reason for the unconsciousness. And as we go further, we will deal with the different causes and their management. The first would be the general approach, how to deal with a patient who is brought in an unconscious condition and where you do not have sufficient time to take the history and again go for the elaborate examination, investigations, etc. So once the patient is brought to you in an unconscious condition, the first and foremost thing would be check whether the patient's airways are open or not, whether the patient is breathing or not. And if there are no signs of if there are any signs of blockage, like in oral cavity itself, you may have saliva, blood clot, or any foreign body, etc., they should be removed. And if the patient has a labor, high pitched breathing, that's a sign of a blockade, respiratory passage blockade, so which needs to be cleared. And whether the patient is really breathing or not, the next thing. And check for the pulse or the heartbeat. If the patient is breathing and the heartbeat is still felt, then you have a slightly lesser emergency condition. Suppose the patient doesn't have a heartbeat, you are not able to feel the pulse, and breathing also is suspicious. That's sign of what we call as a cardiopulmonary arrest. So cardiopulmonary arrest is the most critical emergency where the patient may die within a few minutes, where the intervention has to be done immediately. So we'll start with that kind of a condition as such. Now, sudden cardiac arrest causes is the next part. We will go into the causes next. The first part is about how you see the patient or how you confirm that there is a sudden cardiopulmonary arrest. The predominant, these premonitory signs of a sudden cardiac arrest are patient collapsing suddenly and where there is no pulse as such, and the breathing is not there, and the patient is not having consciousness, an unconscious patient. Prior to that, maybe the patient may have the symptoms like a severe chest discomfort, breathlessness, weakness, or a tachycardia or fluttering, pounding heart palpitations may be felt by the patient. So, if at all you get that kind of information prior to the episode of conscious unconsciousness, that could also be a sign of cardiopulmonary arrest. A late sign, suppose the patient has come to you after about 3 to 4 minutes of the cardiac arrest where the circulation has failed, then it could be a sign of cyanosis, and pupillary reactions could be impaired. And when I say impaired pupillary reactions, the pupillary reactions to the light. See, pupils constricting to the exposure to the light or relaxing after that, that's the sign, or the reflexes being absent. And these are signs of poor prognosis. But you may not declare death at that moment. To declare death, the protocol is there should be no heartbeat for 5 minutes even after attempts for resuscitation. That's the standard protocol for the declaration of the death. But cyanosis and impaired pupillary reactions suggest about a cardiopulmonary arrest which has been there for a considerably long period, and chances of recovery would be lesser, and your approach should be energetic. Now, in any patient with that cardiopulmonary arrest, the first and foremost thing is the resuscitation has to be done. So CPR, cardiopulmonary resuscitation, a very standard universal protocol which has saved the life of many patients, and it's now in the domain of public. Like it's not only the medical domain. Training in cardiopulmonary resuscitation is given to the common man, and so that the life could be saved. And I think many of you might have been exposed to these trainings or the exercises of CPR with maybe mannequins or even other ways. So we'll go into the very basics of that. The definition of cardiopulmonary resuscitation would be like it's a procedure used when a patient's heart stops beating and breathing stops, and it can involve compressions of the chest or electrical shocks along with the rescue breathing. So it's a life-supporting treatment, which is an artificial and manual external cardiac massage. That's how it's defined as such. Now, to prepare for the CPR, and what are the steps of the CPR? The first and foremost is you have to maintain an open airway and ensure that the patient is provided ventilation, so to provide air into the lungs so that the lungs can exchange. Now, all that whatever we discuss would be how to achieve these goals of maintaining a open airway, and how to ensure that the patient receives the circulation, this air into the lungs, and the air exchange can occur in the lungs, and you have to promote a circulation to ensure that the blood flows into the periphery by cardiac compression, and if the last resort would be defibrillation. We will go into each of these steps somewhat in detail. The protocol, the general standard protocol of a CPR is the first and foremost is it may not be possible to achieve the goal with a single person, so you need to get help and then check for the vital signs, then the check for the breathing by the lift up chin lifted up conditions. In the chin, this lifted up chin would be to ensure that the patient confirm whether the patient is really breathing or not. If there is a need, you give rescue breaths, like you have to ensure that the air gets in, then CPR has to be performed, and then once the patient has recovered, you need to get the expert help. Now, to ensure that the airway is kept open, we follow a general protocol: head tilt, chin lift position. The head has to be tilted backwards, chin has to be lifted up, and by this you can ensure that the tongue doesn't fall back and the airway will be remaining open. So before you start with the CPR, the patient should be kept on a horizontal surface, flat surface, and should be supported well, like in the sense when you do the resuscitation, patient should not fall. So select an area where the patient, you can have a sufficient support to the patient, and then ensure that head is tilted backwards and the chin is lifted upwards so that the patient's airway is kept open. And the another ensure that the airway is open, you push the jaw upwards, so that the tongue doesn't fall. So by this, many times the patient may start breathing. If there is a blockade of the airway due to the tongue fallen back, many times the patient may start breathing. Or if there is accumulation of saliva also may be able to flow out as such. Now, of course, you have to confirm whether the patient is breathing or not, but not more than 10 seconds. You are not supposed to waste time to see whether the patient is breathing or not for not more than 10 seconds. Then, to ventilate the patient, ensure that the air gets into the lungs. The one of the easiest means will be mouth-to-mouth breathing, where the mouth is kept open, and with the mouth of the assistants, you have to push the air in, blow the air in as such. Now, if not, the other alternative choices would be, of course, the only when you have a mask ventilation available, it could be a mask could be used, and you may blow the air through the mask also, which would be a bit more sophisticated. But in a real critical situation, it may not be possible to get a mask. In that situation, mouth-to-mouth breathing is mouth-to-mouth the ventilation is always a choice as such. Mask is other choice as such. Or if you have a AMBU bag with you, AMBU bag also could be used. AMBU bag is a artificial manual breathing unit, and the basic units, I think you have seen the AMBU bag in the OT. By this AMBU bag, the advantages would be the efforts put in would be lesser, and it's more hygienic, and you can ensure that the pressure of the air is uniform by regulating the PEEP valve, that the pressure in the expiratory valve can be regulated. It has a basic unit of a mask and a inflating bag, and of course, there is a advantage if at all you have a source of oxygen, it even can be connected to an oxygen source so that the amount of the concentration of the oxygen can be enhanced. If you do not have a source of oxygen, the simple air can also be let in. So that's the advantages of the AMBU bag. And AMBU bag is also one of the essential units of an emergency medical kit. And any person who deals with that should be well aware of how to handle a AMBU bag. Of course, it's a very simple procedure. There is nothing special, very complicated issue. All that you have to be sure is that the valve, PEEP valve is kept open, is functioning properly, and the bag should not have a leakage. That's all the issue. Now, once you have started with the ventilation, you repeatedly assess whether the patient has a pulsation or not. To assess the pulse, depending upon the pulse at the wrist level, may not be very accurate because it's a quite distal most pulse. So it's always better to feel the proximal pulses like either the axillary artery or maybe the carotid artery pulsations have to be assessed to confirm whether the patient's heart is beating or not, whether the pulsation is available or not. If the pulsation is not felt, then you have to ensure that the circulation is facilitated and is needed, and to ensure that you have to start with the chest compression protocol. Chest compression protocol, the general protocol for an adult would be place the flat surface of the palm on the chest and place the other hand on the top, compress the chest, and it would be preferably at a rate of 100 per minute, and it should not be too deep or too flat. The average range of pressure or compression of the chest in an adult, now when I say 3 to 5 centimeter, is for the adult at 3 to 5 centimeter, and ensure that the compression is equal and there is sufficient for time for relaxation also. It's not that you only compress, relax at the rate of 100 per minute. That would be the standard as such. Now, if when you put the pressure, the palm should be kept in a proper manner depending upon size of the chest. If the patient is an adult, then both the hands are used. If it is a child at the maybe at the age of less than 7 years, then you need not use both the hands. It could be one hand. If it is a newborn infant, it's only 2 fingers would be enough. And in case of an adult, it should be 2 to 3 inches, whereas in a child it should not be more than 2 inches, and in infant 1.5 inches would be the optimum. And the chest compressions at a rate of 100 per minute have to be done as such. Now, there is a bit of controversy. Guidelines are changing. So, earlier guidelines, older guidelines would be the preference would be for the air pathway. The chin up position is the first priority. Then breathing is the next priority. Circulation is the third priority, and the rate compression rate would be approximately 100 per minute. And after 15 compressions, you have to ensure that there is a ventilation, you have to give a breath, and the ratio is 15 is to 2, which is the 2000 old guideline. But later the guidelines now have changed, and the current guideline is 30 is to 2. You have to press 30 times and then give 2 breaths, and this is the protocol. And the latest guideline of 2015 says that the priority should be first to the circulation, next to the airway, and then the next is about the breathing. Like, so you have to ensure that the circulation is maintained. So chest compression is started, and by the time the chest compression is started, you check for the airway. So priority is slightly changed in the current guideline, latest guideline, and comparatively the results are seeming to be better with this kind of a guideline, and the rate could be enhanced. The compression rate could be enhanced beyond 100, also 100 to 120 per minute, and the compression ventilation ratio is ideal for 30 to 2. 30 is to 2 is the ideal compression ventilation ratio. What I mean by that compression ventilation ratio is when you compress 30 times, immediately after 30 times compression, 2 breaths have to be given by in the form of ventilation, mouth or the other way. Now, the other way, the target also can be fixed by based upon the oxygen concentration. If you have a pulse oximeter and can measure the oxygen concentration, you have to achieve a concentration of 85 to 95 by 5 minutes of the resuscitation. And it may be a gradual process. By 1 minute, it should be 60 to 65%, and 2 minutes to 65 to 70%. And if the gain in the oxygen concentration is within this limit, like, then probably you are sure that your resuscitation efforts are going to be successful. If you are not able to achieve this target, either you have to review your resuscitation procedure, that compression and ventilation procedure. There could be some errors in either the rate of compression or the ratio of compression and breathing, or it could be the volume of compression or the volume of breathing. Anywhere there could be an error, or it could be like the patient's status is such that patient may not recover. So to assess whether you are doing successfully or not, the CPR, the concentration, oxygen concentration should be above 85% by 5 minutes. Then you can say that the CPR is successful. Now, suppose the CPR is not successful and the patient has still doesn't have a pulsation seen. So even after the CPR done for 5 minutes and it's not seen, the pulsation is not seen, then the other choice would be defibrillation. Defibrillation is principally applying a shock, electrical shock over the heart surface, so that it abolishes all the previous focus of the rhythms, and then a new rhythm may start, a regular rhythm may start as such. So it's something like shutting down the computer and restarting the computer. So it's a high risk protocol, but it would be done only after a failure of the CPR. So that step-by-step protocol should be followed properly, and defibrillation is the next choice. And the defibrillation ideally is done within first 8 minutes after the arrest. Sooner the better, earlier the better, but defibrillation done after 8 minutes of the cardiac arrest would have a very poor results. So whether that defibrillation is really helpful or not would be the timing in which you have started the defibrillation as such. Defibrillators are again of two categories, monophasic and biphasic. What we have in our ICU is a biphasic one, and biphasic is considered to be a more efficient and safer than monophasic. is a bit technical issue. Will not go beyond that. Success rate of the biphasic defibrillation is high. It's around 90%, whereas the monophasic defibrillation, the success rate is around 60%. Chances of burn or the complications like trauma with the biphasic defibrillation is lesser than the monophasic defibrillator. So it all depends upon which type of the defibrillator you have, and you may use the defibrillator of your choice. And the only difference is in the monophasic, the current is flown from one direction and there has to be a proper earth connection to the patient's body. Whereas in the biphasic, you have two poles, so current flows across the body, and hence that could be the ideal. Suppose the patient has recovered after the defibrillation, then you have to maintain the patient on a recovery position. Recovery position is a standard position in which the patient has, a unconscious patient has to be kept as such. So the patient has to be gradually tilted from the flat surface to a side and ensure that one leg is flexed up as such and the head is tilted to a side. Preferably the head end is lower so that if the patient vomits out, that doesn't get aspirated. So this is also called as recovery position for the every unconscious patient. Suppose you have a patient who is unconscious and doesn't require a CPR, even then the same position has to be adopted. So the thing is, you have to decide whether the patient requires a CPR or not. If there is a need of CPR, get the CPR done, and after achieving the CPR, recovery position is adopted. If there is no need of CPR, then the patient is kept in a recovery position. Every unconscious patient has to be kept in a recovery position. Recovery position is head end is slightly lower, and the patient is kept on one side, preferably left side. It could be left or right. Again, there is not much of a difference. And when you position the patient, ensure that the patient doesn't get any injury due to your movement. So movement should be, that handling of the patient should be very careful. So initially you flex the arm, then give a support at the shoulder and the hip, gradually turn the patient to a side. If you do not follow this, and these protocols also are important in operative theaters where a patient under anesthesia is handled, so that joints, hip joint, shoulder joint area, neck, they need to be supported when you handle the patient who is unconscious as such. Now, the patient has to be shifted to the intensive care unit where the patient has to be monitored closely and monitor vital signs every 1 hour and watch for any of the complications. And then the detailed protocol of dealing with the patient who has a cardiac complication, assess the cardiac issues, a specific treatment may be required. We will go into that level only at the end of these assets, like management of specific cardiac conditions. So the first protocol will be about the cardiac arrest and CPR. Common causes of the cardiac arrest are patients who have a previous arrhythmia, having coronary artery diseases, airway obstruction or hypoxia, pulmonary embolism, tension pneumothorax, electrolyte imbalance, hypovolemia, anaphylaxis, drugs or poisons, or sepsis. We will deal with many of these conditions in detail later after having certain preliminary discussions. Then when we go into the specific causes, we will deal with these causes in detail later. Certain complications of the CPR are quite possible, and the complications could be the rib fractures, laceration over the surface of the wound, over the surface of the chest, injury to the liver, lungs, spleen, etc. Aspiration or vomiting also can occur during the CPR, which can be considered as the complications of the CPR. Of course, there are often many questions like whether the CPR is mentioned in Ayurvedic texts or not. Of course, Sushruta doesn't mention about the CPR in that standard protocol, but in the context of grasa shalya, the aspiration of food, Sushruta mentions about a protocol, grasa shalya skandhe mustina abhiyanyata, nishankam mustina abhiyanyata, the protocol of hitting over the shoulder area in a patient who has asphyxiated due to the food in the throat is one of the protocol, which is a primitive sort of CPR. I don't say that the CPR is described in detail, but a very primitive thought of CPR is mentioned in Social Samhita also. Now, The next level is you have a patient who has been stabilized after CPR, or the patient who doesn't require CPR. There is a standard emergency checklist. WHO has released a standard emergency checklist how to deal with a patient with unconscious conditions, and where you can take the history. And this checklist is quite essential, where the first is you need to know whether the patient has any previous or whether the patient requires any immediate intervention or not, like whether the patient is bleeding, or if the patient has a total respiratory failure or so on, or a ruptured organ system, head injury, so on, whether the patient requires that or not, and whether the patient is having a severe allergy history, or then yeah, whether the patient has complications like pneumothorax, and whether the patient really need oxygen support or not. These are the issues which you have to have a checklist, and this checklist will give you an idea of how to go ahead with the further management. So any patient who is brought in an unconscious condition, and you decide whether the CPR is required or not. If the CPR is required, CPR has to be given and the patient has to be stabilized. In a patient who doesn't require CPR, you need to have a checklist assessment, and then which can help you in planning the management next. The next part of the management would be, now again, I will prefer these levels based upon the severity of the condition or the need of quickness, like. So next part, suppose a patient has a stable cardiac condition, the next part is respiration. You have to ensure that the patient has a proper respiration to keep the patient alive. So the first of the target in that condition, in all these conditions in emergency, would be to ensure that the patient is kept alive, so that you can go to the next level where investigations are done, and then a specific management could be managed. Now, the next life-threatening condition would be respiratory failure. A patient who has a cardiac failure, cardiac pumping failure, may not survive for 5 minutes. A patient with a respiratory failure may not survive beyond 15 minutes. So, comparatively, you have a bit higher time range as such, but still it's an emergency. Now, respiratory failure is defined as a situation where the oxygen supply to the body is not sufficient to sustain the normal life activities. And for our practical clinical purposes, we consider respiratory failure under two heads. One, a respiratory failure where the oxygen concentration cannot be achieved by the lungs. Lungs are diseased, and hence, even if the concentration of oxygen available to the patient is sufficient, he cannot just take that oxygen in, which is actually a real respiratory failure at the lung tissue, where the lung is diseased due to diseases like maybe tuberculosis, pneumonia, etc., and so on, and if the lung tissue are fibrous. Type 2 respiratory failure is a ventilatory failure, where it involves low oxygen and there is a high carbon dioxide accumulated. Now, in a type 2 respiratory failure, it's often due to obstructive pulmonary disorder, where the ventilation is not enough, or the chest wall injury, and so on. So that's the other way. And in that condition, these differentiations are important to plan the management. In the type 1, oxygen concentration as well as carbon dioxide concentration will be lower. Whereas in the type 2 respiratory failure, oxygen concentration is lower. At the same time, the carbon dioxide level would be higher. So when you plan the management, you need to take care of that carbon dioxide expulsion also is not enough if you provide oxygen alone. Whereas in case of type 1 respiratory failure, providing the oxygen could be good enough to sustain the life of the patient. So that's the importance of assessing this. Providing oxygen alone in a patient with the type 2 respiratory failure would not be enough. So if at all you have the facilities, then you may have the investigations like spirometry, blood gas analysis, pulse oximetry can help to differentiate these conditions. But primarily it has to be by the clinical examination. The clinical examination would be if the ventilation, the breath sounds are nearly normal, inspiratory and expiratory breath sounds are nearly normal, it could be a type 1 failure. And if the breath sounds are particularly inspiratory sounds are very feeble and expiratory sounds are prolonged, that could be often a type 2 respiratory failure. That's how it has to be dealt with. Now, when we plan the clinical management, the primary approach and the best facility which we have to deal with would be hypoxia can be managed. Oxygen concentration to the body has can be managed better, and hence the hypoxia could be again classified as hypoxic hypoxia, anemic hypoxia, stagnant hypoxia, and cytotoxic hypoxia. What I mean by this is if the patient has a reduced oxygen level or a respiratory failure due to improper availability of the oxygen. When I say improper availability of the oxygen, it could be like the concentration of the oxygen in the air breathed in would be lesser, like a patient who is suffocated in say condition like smoke suffocation, or maybe somewhere there is a compression in the throat or an obstruction in the respiratory tract, which could result in hypoxia. Anemic hypoxia is where the oxygen carrying capacity of the blood is not optimum. So even if you provide oxygen, it may not be able to carry the oxygen to the tissue, and the tissue respiration may not be maintained. When I say anemic, hypoxia, it doesn't mean only anemia which has been resulted. Like even in a carbon monoxide poisoning, it's a anemic hypoxia. In the sense, carbon monoxide poisoning, the hemoglobin will be permanently blocked with the carbon monoxide, and hence it cannot be again. It cannot carry the oxygen, even if you have sufficient hemoglobin level in the plasma, it cannot carry. So, in such a situation where either the hemoglobin itself is deficient in a patient who has acute bleeding, it could be anemic hypoxia, where even if the hemoglobin concentration is good enough, it's not enough to reach to the tissue. Or in case of carbon monoxide poisoning, hemoglobin concentration may be proper, but still oxygen carrying capacity will be lesser. And of course, in an anemia where the hemoglobin concentration is lesser, hypoxia can be resulted due to the same reason. Then the stagnant hypoxia is where there is a circulatory failure. See, even the patient may have sufficient oxygen to the in the lungs. Oxygen may be capable of getting exchanged in the lungs, but if that oxygen cannot reach to the tissues, if there is a circulatory failure, patients who have a low this shock condition, patients in shock conditions. So shock is another issue which we discuss in the next part. So shock is simply a situation where the blood cannot reach to the tissue in sufficient quantities. Simplest description. That's the stagnant hypoxia. Or cytotoxic hypoxia is where even if the oxygen concentration is available to the tissues cannot take up the oxygen because of the some toxic damage to the tissues. The enzymes which are responsible for the metabolism, they are not capable of doing that, as in case of poisonings. So a patient with a respiratory failure and having hypoxia may have any of these categories. And this where your management approach would also be based upon the type as such. Providing oxygen would be simple. Providing oxygen would be helpful only in hypoxic hypoxia. Whereas in the other hypoxia conditions, you need to take care of the other issues. Patient who has a impaired oxygen the absorbing capacity in the blood, you need to enhance that, and usually preferably by a fresh blood transfusion. A stagnant hypoxia, you have to ensure that the circulation is maintained, so you need to administer the drugs which will ensure that the blood circulation is maintained or the circulatory pressure is maintained properly. Patients who have a toxicity, you need to have anti-toxic regime so that the tissue is survivable. So approach to the management of hypoxia in those conditions would be different. But from our discussion point of view, the primary issue would be about oxygen. So we will start with the protocols and guidelines of oxygen administration assets. Now, oxygen is a drug, and it is described as a prescription, or it needs prescription. Without really a prescription, doctor's prescription, oxygen cannot be dispensed. Now, this is about the controversy, like whether oxygen availability is freely available in the environment, and hence you do not have a marketing right on the oxygen, or whether the oxygen is a drug which is prescribed as per the this, drug and cosmetics law. Oxygen is a drug and it should be prescribed with the only after prescription it should be dispensed with. The without prescription it cannot be. It's in a schedule H asset, so it's limited prescription asset. So further controversies, debates on that issue is not the target now. And it's a treatment for hypoxemia. Hypoxemia is where the patient, the primarily is a hypoxia is a hypoxemia. And in actually all acutely unwell patients, not at a risk of the type 2 respiratory failure. See, in a type 2 respiratory failure, if you provide oxygen, still the patient may not help, as the patient may not get sufficient help because the carbon dioxide concentration has to be evacuated. So, simple oxygen administration would not be enough in type 2 respiratory failure. And it should be, it always, once you start the oxygen this provision, the target would be at 94 to 98% asset. Suppose at the patient who have a type 2 risk asset, type 2 respiratory failure, a target of 80 to 88 to 92% still is suggested, which can sustain the life, though it may not be a complete treatment. But there you need to ensure that the carbon dioxide also is removed by having other ventilator support. We will go into that, like how to do that. Then, in most breathless and non-hypoxemic patients, supplemental oxygen is not required. It's not that the oxygen is provided in every breathless patient, only in those patients who have hypoxemia, where the hypoxia is where oxygen is needed. So, connecting oxygen cylinder to every patient is not the right thing. Now, you have seen oxygen cylinder and you have seen that how it's administered. Essential components of that, the things which you have to know about that oxygen administration is, of course, oxygen is provided in a black color cylinder. There's a universal color code. So, oxygen always is provided in a black colored cylinder. And the screw cap of the oxygen connector is always of a standard type, and it so that you will not have that flow meter of other gases connected to that area. So there is a, these are all the safety precautions. Color code of the oxygen cylinder and that screw type also is a standard one. Now, in that your oxygen provider, there are certain basic issues. One is there is a pressure gauge. That pressure gauge measures the pressure of the oxygen in the cylinder, in the source as such. Then there is a flow meter. That flow meter which measures the amount of the oxygen flowing as such. So you'll have a bubble like a button which raises up or down as oxygen flows, and you can get the reading like how many liters per minute or liters per hour of oxygen is provided as such. So depending upon the type of the flow meter, it could be meters per minute, liters per minute or liters per hour. You get that. And then there is a knob to get adjust the flow. And there is a humidifier. That humidifying cup also is essential. Oxygen always has to be given along with the humidity. A dry oxygen can be harmful. So it's essential that there is a humidifier, and this humidifier ensures that the oxygen bubbles flow through the water and then they are reaching out, so that the patient gets oxygen along with the sufficient humidity, which will not damage the tissues. So these are the essential components of a oxygen administrator asset. So oxygen delivery system could be, now that's from the cylinder to the patient, you have that oxygen regulator, and then to deliver to the patient, the different tools could be used and different varieties of the materials are used. We'll discuss the advantages of each of these and the common varieties which are used as simple nasal cannula, which is very often used in our ward, or simple mask, which also is used as it. Then partial rebreather mask, of course, we do not have that the partial rebreather mask in our ward, but in OT we have that rebreather mask, different types of rebreather mask. Venturi mask, of course, we do not have it in our condition. Oxygen hood, oxygen tent, these are the materials which we do not have in our unit, but these you should have some idea like what is asset. AMBU bag, of course, is another option where we can have a ventilation, support to the ventilation. AMBU bag we have already referred to in case of the defibrillation issues. And the tracheostomy collar. Tracheostomy, though you have seen many patients with the tracheostomy, and TPC is actually in the ventilators. Ventilators is one of the issues. So we will go into each of these. Like the nasal cannula, commonly used is the nasal cannula. It's a disposable plastic and devices with the two protruding prongs which can be inserted into nostrils, and it can achieve a concentration of 24 to 44%, not beyond that. See, environmental oxygen concentration is around 20%. So it only the advantage extra concentration of the oxygen achieved by nasal cannula would be about 4 to 20% additional. So 24 to 44% is the maximum concentration achieved by the cannula. And a lot of oxygen is wasted. See, the oxygen which you have administered once, if the patient takes in, fine. If the patient doesn't take in, it's wasted as such. So though the instrument is less costly, the process becomes costlier, and the real help to the patient would not be sufficient. It's good enough if the patient has only a moderate hypoxia and it's a real hypoxia. In other types of the hypoxia, nasal cannula cannot achieve the target. It doesn't help in this asset. Now, how far the concentration is achieved? If it is at 1 liter per minute, the concentration achieved is only 24%. That's 4% in addition. 2 liters per minute, 28%. 3 liters per minute, 32%. 4 liters, 36% concentration. This is about concentration of the oxygen in the air breathed by the patient. It's not about the concentration of the oxygen in the patient's body or the blood concentration. It's about the concentration of the oxygen in the air breathed by the patient. Whether this would be enough to maintain the oxygenation of the patient would be the other decision factor. So the scope of real advantages of the nasal cannula would be relatively lesser. The simple mask is the other way. In the simple mask which we use, is a mask where the oxygen goes in. So comparatively, the loss of the air would be lesser. A rebreather mask would have a bag so that the air which is breathed out again is stimulated, and hence the wastage of the oxygen can be reduced. The advantages of the rebreather mask would be only that there would be a lesser loss of oxygen, or you may be saving some amount of the oxygen. The same the air which is breathed in would be taken in and taken out. With these rebreathers or non-breather masks, where we have a bag connected to, and the air will be this mask has to be kept very tight so that there is no leakage, and air is breathed in and breathed out. After a certain period of time, the carbon dioxide concentration in the circle, this air within can be enhanced. So you need to give an outlet regularly. Venturi mask is a mask where you have a valve where the pressure is measured and pressure is already regulated, so that you get the air in through a separate pathway, and the air breathed out goes through a separate pathway, so there will be no mixing up of the air which is breathed in and breathed out, and hence the efficiency of the oxygen level in the environment, this air breathed in by the patient is better. In the breathed out air also, the oxygen can be to a certain extent saved and filtered out, so that the wastage is reduced and the risk of or complication of possible carbon dioxide accumulation in a closed mask is reduced with the venturi mask. So venturi mask is somewhat more advanced as such. Simple oxygen mask, the advantages would be more than cannula. It can reach up to a rate of 35 percentage of 35 to 60% of oxygen. So comparatively, it's more efficient than the simple cannula, and you can administer up to 10 liters per minute. And that it has a vent on the sides so that air can leak to a certain extent. So it's used to increase the delivery for short periods. Then partial rebreather mask is oxygen directed into the reservoir, this reservoir is there, and the patient breathes in as such. So the one another drawback of this is the dead space of the air, this breathing in would be more, because the patient has to take the air in from the reservoir also. So in a patient who has a reduced respiratory effort, this is not good enough as such. It delivers up to about 60% of the oxygen concentration. And non-breather masks is again same, the basic issue. It can achieve up to 75% of the oxygen concentration. Ventilator masks are where you have the ventilator kit, where you have these valves and regulators where the flow rate can be exactly regulated. And in the ventilator mask you will have the different color coded valves, and the color would be like a color, blue color would be having 24% diluted, yellow color will be 28%, orange will be 50%. So orange is the last one where you can have exactly calculated total gas flow can be calculated more accurately, and the total efficiency of the system can be enhanced. That's only the advantage of the venturi mask. But again, it doesn't help in the real ventilation as such. Then oxygen chambers, these are used mainly in the pediatric units where the child is kept in the oxygen chamber. You do not have any instrument directly coming into contact with the patient's body. Even in the other adults also, in certain hospitals, certain conditions, it could be. The basic advantage of this would be the patient's condition or patient's physical condition would be better. The environment will be somewhat the same as such, and in the closed environment, the oxygen concentration is enhanced. So, instead of giving a mask, you will have a oxygen chamber. Of course, we do not have it in our unit, so that's about the issue. AMBU bag, as I already discussed, we have already discussed about it. It's a handheld device and commonly used for positive pressure ventilation. Advantages of the AMBU, see, in all these unit instruments which we have discussed till now, you cannot enhance the pressure of ventilation. So you cannot give a ventilatory support. Whether it all depends upon the patient's effort to breathe in and breathe out, that the air is taken. All that what you can do is enhance the oxygen concentration. With the AMBU bag, you can really add to the ventilatory efforts. You can force the air in, but you have a regulatory valve so that even when you push the air in, you will not injure the lung tissues. That regulatory valve in the AMBU bag is very critical to prevent the injury to the lungs. Then tracheostomy is done in a patient where the patient needs to be kept on an artificial ventilator, and where you make a incision, insert the tube, and the tube is connected to a artificial lung machine or ventilator so that it can provide maximum effort as well as concentration of oxygen. Also, it can ensure 100% oxygen if necessary, and all the oxygen can reach in. We also can add to the pressure of ventilation by making use of that instruments outside the body, that ventilators, so that the patient is kept alive and provided the oxygen in assets. So ventilator is again a more sophisticated instrument where then again there are lots of varieties. We will not go into that issue. Either it could be simple mechanical, or now you have computerized ventilators where the effort of ventilation would be measured based upon the patient's requirement. So it adds to the patient's efforts. If the patient's efforts are zero, it could be 100% support by the ventilator. If the patient's efforts are raising up progressively, that effort of the machine can be reduced. So these are the sophisticated ventilators now which are available now. Earlier it was a mechanical ventilator where uniform pressure was given. Now you have a ventilator which can respond to the patient's requirement. So these are all the technological sophistications. We will not go into that. But basically, ventilator is a instrument where the air is pushed into the lungs so that the patient, the air gets into the lungs better as such. That's about the ventilators and respiratory support and oxygen as such. With this, we'll conclude today's session. If there are any questions, we'll try to answer. And we'll continue with the unconscious patient in the next session with other issues related to the unconscious patients. Right. There are no questions. So we'll wind up. Thank you.